This is Talking Heads. Explore the latest in research and policy about serious mental health disorders with Dr. Noosha Niv.
Hi, I'm Dr. Noosha Niv, and today's guest is Dr. Stephen Lopez. Dr. Lopez is Professor Emeritus at the USC Department of Psychology. His research is focused on culture, serious mental illness, families, and intervention. He has studied the relationship between family factors in the course of schizophrenia, particularly among Mexican-American families. The primary focus of his most recent work was to reduce the duration of untreated psychosis among Latinos with their first episode of a psychotic disorder. I'm grateful to call him a mentor, as he was also my dissertation chair back in the day at UCLA. All right. Welcome, Dr. Stephen Lopez. Thank you so much for joining me.
Well, thank you for the invitation, Dr. Niv.
Thanks for being here. So let's start with what led you to the field of psychology, and then more specifically, the focus on psychosis.
So I went to Claremont Men's College, which is now Claremont McKenna College. I was an econ major when I began in 1971. Didn't do so well in econ, but did well in my psychology courses. And my junior year, I changed majors to psychology. It just seemed to fit my interests. It was fun. And I thought about those issues in psychology. And in terms of psychosis, kind of backed into it. My main interest in psychology has been culture and ethnicity and how that relates to intervention, psychopathology, etc. But I was asked to be a consultant on a study that was led by Marv Carno and Janice Jenkins, and Ian Falloon actually was involved in it. And it was to look at expressed emotion among families and as it relates to the course of illness. And so I was the diagnostician, spoke Spanish, speak Spanish, and I was a diagnostician. It was a study focusing on Mexican Americans. And so I had keys to 3 or 4 of the main hospitals, psychiatric hospitals here in Los Angeles. This was in the early 1980s. And from that, I began looking at issues of family factors in conjunction with a student at the time, Amy Wiseman. And so that's really how I backed into it. I still have an interest in culture and still continue that, but it really started with psychosis. And I never thought I would actually study psychosis. I saw that as on the severe end of mental illness and less opportunities for improvement. That was my perspective in the 70s as a graduate student. But now we know so much more and people can lead very full lives. And psychosis has been an interesting area of research, and it allows for the study of culture as well. So that's how I got interested in psychology and the study of serious mental illness.
Okay. And your current research is related to first episode psychosis. And what's the goal of this line of research?
Right. So close colleague of mine, friend, Dr. Alex Kapelowitz, he's here at UCLA. And I started doing some research in Mexico. And one day I called him up and I said, there's a lot of documentation of the needs, mental health service needs for the Latinx community. But why don't we do something about it? Why instead of documenting the needs, why don't we try and improve the mental health status and prevent, at least secondarily, the kind of burden on individuals? And so that led to us carrying out this research, which was to improve what we refer to as psychosis literacy. So the knowledge of psychosis, how to manage it, taking medications, psychosocial interventions, and the like. But how to improve psychosis literacy, primarily so that people early on can identify it in their loved ones. Usually people don't self-refer for psychotic illnesses. And so their loved ones can recognize the illness and then get prompt care. And so we started off in Mexico in teaching people how to identify the signs of serious mental illness. And it expanded here to the United States with largely Spanish-speaking community. But the main goal is to help people get the kind of care early on so that the burden isn't as great to them as well as their loved ones.
Can you expand on that and discuss the importance of getting people into treatment earlier?
Sure. One of the goals of a relatively recent campaign was to, as I said earlier, reduce the delay in getting into services. But to do that, we have to establish a conversation. And so we carried out a campaign which we tried to initiate conversations in communities, in groups, in churches, in schools, with people with mental illness and people without mental illness. And the idea is that if we can enhance conversations, we can get people into care early on. In fact, I recently had a family situation where one of our loved ones developed serious mental illness. And I was told that that's not something that they wanted to share with others. And I respected that. The downside of that is that a person doesn't get the kind of support from the loved ones, doesn't help them think about avenues and options for care. And so really what we want to do is expand the conversation so people can get the support and they can get the care. And oftentimes, if you wait too long, then the individual with the mental disorder is actually less likely to seek care and less likely to continue to seek care once they're getting care. The other thing is that it ends up in an acute situation. Hospitalization is needed, oftentimes an emergency. Sometimes the police get involved, and it can be an ugly kind of situation. And it ends up serving as a barrier for people to continue the care. And so enhancing communication, you can get the support that you need. You can explore options early on in the illness course so that the person can participate in that decision-making, and you can avoid really acute episodes that require hospitalizations that ends up being a very negative experience and doesn't promote continued care. So those are reasons why it's important to get early care.
There's been so much research in the last 10 to 15 years particularly, and the outcomes are pretty remarkable. The earlier people start, the better off they are overall.
Yes. Not only does the duration of untreated psychosis, so the time from the onset of the illness to when they're being treated, that evidence is pretty clear that the shorter time period in which they're not being treated, the better outcomes, both clinical symptoms and also functioning. But in addition, I think it's really important to indicate that that time period can be reduced. At least two studies to my knowledge. One is the TIP study in Norway, and then the MEND study in Yale with Dr. Vinod Srihari have demonstrated that you can reduce that duration of time with campaigns, with getting out the word. And so that over time, people can get the word and get into care so that they can prevent some of the negative consequences. So yes, that time period is really important to keep it as short as possible.
I want to talk about the campaign in just a moment, but before we do that, we know the Latinx population takes longer to engage in treatment. Do you see that as just a literacy issue? Like, why do you think that's happening?
Yeah, it's a great point, Dr. Niv. It's our intervention, our campaign is to enhance literacy. But that's one avenue in which you can hopefully reduce the duration of untreated psychosis. But I really see it as a structural issue, primarily. A structural issue in terms of the availability of Spanish-speaking mental health professionals, the knowledge of primary care physicians, and their ability to refer folks into mental health care as needed. Schools as well. So if I had a lot of money, I would invest in ways to enhance the structure of care in the different ways in which people actually reach services. So yes, literacy is an important point. And the campaigns have often argued that we want to enhance literacy and we want to reduce stigma so that people can get the kind of care that they need. And I think that's important. But if you don't have the structural elements in place, people don't have insurance. People don't know about the mental health services because they're not well known. You don't have Spanish-speaking individuals that have the trust of the Latinx community. Then no matter how much literacy you may have and knowledge of the illness, it's less likely that you're going to get the care that you need. So I think it's not just a factor of literacy, although that's one way of intervening, and we focused on that. It's a lot about the structure of care, in my opinion.
The services and how they're provided.
Yes.
You mentioned stigma. Can you talk a little bit about the role of stigma in surrounding mental health in Latinx populations?
Sure. I think most of us believe that stigma is really an important barrier in the Latinx community. And I think many of us believe that it's greater in the Latinx community. A student, she's now a doctor, made the point that in particularly the Mexican community, ¿qué va a decir la gente? ¿Qué van a decir? What are people going to say? Is a common expression. My dad used to say, his mother used to always say, ¿qué va a decir la gente? My dad said, who's la gente? Who's going to say something? But this idea that people are going to comment, and so that you should suffer from a mental illness or that you should have a loved one with a mental illness. What are others going to say about that is a factor that may play a role in people not getting the care and may be greater among this community than others. I don't have any evidence that that's the case, but I've heard so often from people within the Latinx community, particularly the Mexican origin community, talk about the stigma being greater.
Did you find that about 50% of people who recognize symptoms suggest seeking care from a mental health professional? Am I remembering that correctly?
50%. Say that figure again.
Among people who are noticing symptoms in family, only 50% suggested seeking help from a mental health professional.
You're referring to a particular study that we did?
I may not remember correctly, but yeah, I feel like I read that in an interview you gave, or does that sound familiar?
50% seems high to me.
Okay.
Yeah.
But I think the point being that family members, even if they recognize something's wrong, they are not referring people. They're not suggesting, hey, my son, brother, or whoever, go to a mental health professional. Where are they going for help?
Good question. There's a large literature talking about seeking services from folk healers or seeking services from family physicians and the like. I'm not so sure that people are seeking the services from those individuals. I don't recall recent data in that regard. Here's a wonderful case that we had in our study, and I think it makes an important point about the importance of a conversation. We were in the community. This one gentleman said that he had somebody who he knows was suffering from these symptoms that we call CLAve, which are symptoms of psychosis. He says, I know somebody. And so our community outreach person said, well, contact the number, which was the number to the outpatient clinic. He did not. And then this outreach person goes to a pharmacy and reaches out to the community, sees the same gentleman, and he says, it's my son. And she says, contact this phone number. Doesn't contact the phone number. He texts her a number of times. So he has the knowledge that these symptoms are a reflection of mental illness, but he's not calling. Finally, the son gets aggressive and he calls the police. And he tells the police, take him for drug rehabilitation. He's doing drugs. They say, we don't take to drug rehabilitation. We can either take him to a psychiatric hospital or we can take him to jail. He says, no, take him to the drug rehabilitation center. No, we can't do that. And then the police officer said, because we were involved with the police and did some training with them, the police said, well, if you go to the psychiatric hospital, they have the CLAve program. And he knew about CLAve from our campaign outreach person. And so he said, take him to CLAve. So it's about multiple people having a conversation so that you can feel confident and you can trust that seeking mental health services is the right thing to do. Also, we've been in the community, and some people will say, we can't go to that clinic because we don't have insurance. Well, that's a public mental health system and you don't need insurance. Or we can't go to that mental health clinic because they don't speak Spanish. Well, actually, in that mental health clinic, they have a number of providers speaking Spanish. So the perception that the community has oftentimes is not congruent with the resources out there. But the more we have people talking, police, family members, school teachers, counselors, and people are going to start feeling comfortable. To talk about mental health issues, está loco. This idea of being crazy is really problematic. And so having a conversation, I think it's about trust, really. So they're just not getting the service. Not that they're getting it in some other place. I think they're just not getting it because they don't trust the system. They don't want people talking about them. Mm-hmm. Another situation that I'll never forget, one of our families had a son or daughter who needed acute care. The ambulance came out. They took their loved one away. The next morning, somebody had spray painted on their garage, and this house is a family of crazy people.
Oh.
This house is aquí vive unos locos.
It's devastating.
So again, that idea, stigma, that idea of what are people going to say, that idea of letting out.
So they really have to hear the same message repeatedly from different sources to trust.
Yeah. So structure and trust.
Can you talk a little more about the communication campaign? What does it consist of? What is it teaching people?
I was interested in coming up with common everyday ways of describing serious mental illness as opposed to in clinical or technical terms. Some campaigns talk about schizophrenia or psychosis. I didn't think that was a way to go. Instead, I wanted to come up with ways in which people can talk about it easily. And so I went to my wife, who's born in Puebla, Mexico, and she was a Spanish language instructor. And I said, Leticia, look, I want to teach people about hallucinations, delusions, and thought disorder. Disorganized speech is a way of capturing thought disorder. But say it in a way, in English, and in Spanish, in a way that can be commonly used. So she came up with creencia falsa, which means delusion, false belief, lenguaje desorganizado, disorganized speech, and alucinaciones. What kind of alucinaciones? Ver cosas que no existe o escuchar voces o sonidos que no existe. So the first letter of each of those words, you come up with the word CLAve. And CLAve means guide. CLAve means index. CLAve means key. So use la clave, use the key para identificar enfermedades mentales graves. Mm-hmm. Use the key to identify serious mental illness. And so we go into the community and teach people about la clave. When we first developed this idea, we would use popular cultural icons to illustrate each of the symptoms. So creencias falsas, we used a snippet from a song by Maná called El Muelle de San Blas. And El Muelle de San Blas, which is the pier of San Blas, it's a real port in Mexico. In El Muelle de San Blas, a woman believes that her lover's going to return, and everybody knows that he's not. And she ends up living in the pier of San Blas, and she's decompensated in terms of her dress and other ways. So that was an example that everybody knows that song. They don't necessarily listen to the lyrics and really think about it, but that resonates. And then lenguaje desorganizado, we used a clip from Cantinflas, who was a very famous Mexican comedian who would go from one idea to the other without any clear connection. And he did it for comedy. And everybody knows Cantinflas. In Alucinaciones, there's a song by a Puerto Rican group, sung by four, named Sofia en Ocasio. She lost her mind when she started seeing her lover and hearing him and seeing him. So we would use these popular cultural icons to get people's attention in an entertaining kind of way so that they could recognize it. But our main emphasis of the campaign was that we developed a narrative film, a 15-minute brief film. This was all funded by the National Institute of Mental Health. And we hired a Hollywood director, Patricia Cardoso. She's Colombian, did the movie Real Women Have Curves. You may have seen that movie. And we have a 15-minute film that you can see if you go to our website, uselaclave.com or uselaclave.com. And it communicates this whole process of family members who have an adult daughter who starts developing delusions, false beliefs, and they think she's just stressed out because of the divorce, and they don't consider seeking care until a neighbor who has a son with serious mental illness says, I think it's something more than that. No, not the stigma. That's not my daughter. No. And then she finally gets the care that she needs as a result of the input from the mother. And that's the core of our film. So we would go into the community, as I mentioned, schools, churches, health clinics. The swap meet was one of our best places. We would just hang out there and hand out brochures.
Interesting.
So we got the word out about CLAve, and in an effort to get them coming into the clinic. And we measured then the treatment delay of people with first episodes over a 2-year period after we did the campaign.
That's amazing. And were there particular aspects of public health messaging that really resonated with the population you were approaching? You talked about popular icons. Did you find anything else that really worked?
I think this narrative film was really helpful. To give you an example, we went to a church, maybe there were 30 people there. And when we administered the film, we'd first do a little introduction. And we asked the questions, what's mental health? What's mental illness? And people would raise their hand and they would describe. And this one woman says, I know what mental illness is, but I'm not going to share it with you. Okay, left it at that. Watch the movie. After the movie, people really chimed in, and it kind of opened the door to having these conversations. And this one woman disclosed that it was a family member who suffered from a mental illness, and she began to talk about it openly. So I think seeing this movie, opening up people's eyes that this can happen, this is real, and other people willing to talk about it can open up the conversation. Now, I don't think a movie, this 15-minute movie, is something specific for the Latinx community, but I think it just captures really nicely some of the key barriers to getting care, and then the fact that there's hope. That's one of the main messages of this movie, is that by getting care early, you can have your loved ones leading full lives. Hope, I think, is really important. But I think this translates across communities. But the fact that it was in Spanish, it used idioms that made sense to people. And there's no question that the movie enhanced psychosis literacy. We did a number of studies. We did it online compared to a TED Talk. We did it with health promotoras administering this. We did it when we administered it. We did pre and post. We did experimental controls. It's no question that the movie and our different ways of teaching about psychosis really enhance psychosis literacy.
That's really interesting that compared to like a real life presentation, there'd be a significant difference.
Yeah.
Can we switch gears completely for a moment? And
sure.
I had Shirley Glenn on the podcast a few weeks ago, and we talked at length about the negative impact of family factors or family criticism and hostility on outcomes. And your work has also looked at the relationship between family factors and outcomes in schizophrenia, particularly among Mexican Americans. But you've really looked at it from a very different angle. You spent years studying what families are doing right. What are they doing well that's protective? What have you learned?
That was some time ago. I really enjoyed that line of work. A couple things that we learned. One is that with one of our samples, and Mexican American samples, that warmth predicted the outcome or relapse rates, so that those persons with schizophrenia who were living with families that were high in warmth were less likely to relapse 9 months later. And there were only 2 other studies, and there were over nearly 30 studies at that time, and only 2 other studies even considered a positive aspect, warmth in particular. One was out of the old Yugoslavia, and another one was in Italy. So one thing that they shared was the Catholic faith. We didn't look to see whether or not that played a role. But for me, I think it's really important to look at what families are doing in a positive way, as well as what families might be doing in a quote negative way that plays a role in the outcome. So the implication of our finding about warmth is that therapists should not just be focusing on decreasing negativity, whether characterize it as hostility or criticism or emotional over-involvement, but that you also think about how to build on the strengths of the family and their caring and their connections. And I think some of the early research in family interventions did point out the importance of positive communication, for example. But I think overall, the emphasis has been about the negativity of family. So that's one thing that we learned.
What is warmth?
Yeah, really, it's a good question. Thank you. The way it was defined, and keep in mind how these constructs were measured. What I really liked about the study of warmth and criticism and emotional over-involvement, et cetera, is that it was based on families talking about their loved ones with schizophrenia. And it's expanded to other disorders as well. So they're talking about them. And so warmth is tonal. On a measure of 0 to 5, to what extent does a person show interest in their loved one? Do they speak in it's more on the affective domain than it is, quote, positive remarks. There's another index that's referred to as positive remarks. You can say positive things about the loved one, but that's not related to outcome, at least in our studies. And in general, positive remarks isn't. But warmth, this kind of tonal interest and warm tone as well, the way they're talking about it. So if they say, Joe relapsed last week, or Joe didn't take his medication, or Joe, he's really trying hard and just having a hard time. So the tone in which the person is expressing their challenges can play an important role. So it's more on the affective domain and the interest that they have in the individual. I remember this one mother saying, Joe and I watch TV every night and just really enjoy watching TV with Joe every night, showing an interest versus Joe's, very clean, or Joe is a hard worker. Those positive remarks aren't as related as that affective tone.
There's a connection and empathy.
Yeah, that's certainly part of it. So the other thing that we learned is that the difference between the perception of the ill relative versus the perception of the caregiver. And so we measured not only warmth or criticism, but we also measured the perception that the ill relative had of their caregiver. And it's not always congruent. Mm-hmm. Yeah, some people can see the negativity in a positive way of caring, or they can see their warmth and involvement as being critical. And so that disconnect can play an important role. And it opens the door for family interventions and clarifying how people communicate and how people receive that message. Those are two key messages that we learned in that line of research. It's been a while since I've thought about that. Thank you for bringing it up.
Well, that's what brought me to you. So years and years ago. So I appreciate it. I want to jump to some questions I got in the Facebook group.
Okay.
The first one is, I keep hearing about culturally competent care. What does that mean?
Yeah. A lot of people have written about culturally competent care. The current view is cultural humility. But my view is it's about shifting lenses. Culturally, in the past, people criticize existing interventions, existing models as being not considering culture. And so people have gone the other extreme and say we need a psychotherapy that's tied to a particular group or embedded with particular cultural concepts. And I believe that we need that kind of information, but I think it's more about shifting between the client, the consumer, and the family's perceptions of things and accessing them, and then using them as you intervene and assess with your knowledge, your norms, your models. And so it's about, again, I guess I'm using the word conversation again. It's one, accessing the client and family's views and presenting your views, and then negotiating what's really an understanding. What's the best way of understanding this? So, for example, an area that's of great interest, people with serious mental illness, medication. So family member says, I don't want to take the medication. And the mental health practitioner says, well, I think it's really best to do so. Those are two cultural notions, if you will, about how you address mental illness. And coming up with a shared understanding and a shared narrative, as opposed to just drawing on the client's view or imposing your view. How can we come up with a shared narrative, including, okay, you don't want to take medication, but let's monitor this every week. And if we see any signs that are concerning, let's intervene at that time. How does that sound? In my view, that's culturally competent care, that you're accessing the client's view, you're presenting clearly your view, and then you're coming up with a shared understanding.
You're negotiating that if needed.
And negotiating it. And sometimes you're not going to be able to negotiate because the client is adamant they're not going to take the medication.
That's such a great segue to the second question, which is, my family is Catholic. My husband is prescribed an antipsychotic, but our pastor told him not to take it, that God will heal him. I'm not sure what to do.
So again, what's their conception and construal? What are the advantages and disadvantages of accepting the pastor's view? And then what are the advantages and disadvantages of accepting the mental health point of view that antipsychotic medication is useful? And then coming up with a shared understanding. Of course, I, as a clinician, would say my experience has been that people benefit from those antipsychotic medications. Is there a way that we can draw on your religious beliefs to help you and your family member with this illness? Prayer, attending church services, involvement in the community, but at the same time using the medication. So acknowledge and support their religious views. Maybe even having a conversation with the pastor and saying, tell me more. God can be very present and God can help it, but God also helped us come up with these medications as well.
Okay. A couple more. I'm just getting started with a therapist. How can I determine if the therapist will understand my experience as a first-generation immigrant? Are there specific questions you think I should ask? That's a tough one.
Yes. Ask him, how well are you familiar with first-generation immigrants? That's not going to get you very far.
Yeah.
I think it's your job as a client, as a consumer of services, to talk about things and see how well they're received. And you can start addressing some touchy issues and get a sense of how they respond to that. So, for example, what does it mean to you to be a first-generation immigrant? Are you concerned that they may have some stereotypical notions about that? And you can share those concerns with your therapist and see how they respond. But I think the best way is to start addressing issues and seeing how they're responding to those issues.
What do you think, for someone who's reached out to several therapists, seeing who they connect with, what do you think of the appropriateness of just asking, what is your experience with first-generation immigrants?
I think that's very appropriate. And maybe a clinician may not have any experience with working with somebody of that background, but they may be showing that they're interested and they're learning and they're asking questions and they're willing to look at the life experience from their perspective. So even though they don't have the background in working with that population, they may be very open to learning about that. Now, as a consumer, you don't want to have to teach people about your experience so that it takes away from the point of receiving the services. But how open is this person to learn from others? And you can get a good sense of the therapist vibe in direct kinds of ways. And so I would encourage this person to really think about it that way.
And last one is, should I look for a Mexican or Spanish-speaking therapist? Does it matter? And then I went back in the poster, clarified that they're Spanish-speaking Mexican.
Right. If it matters to them, then they should. There's a literature out there in terms of to what extent do people of Mexican origin prefer people of the same ethnic background. And there's different points of view. I think if it matters to them, they should try and seek services from somebody who speaks Spanish, if that's important. Obviously, if you speak Spanish, they get somebody who speaks Spanish. But if they're bilingual and they prefer somebody who's knowledgeable about Spanish, they should do everything they can to seek services from that, if that's important to them.
There data about matching?
Yeah, there are data. There's some data that show that matches lead to more positive outcome.
Okay. And the last question is, what are you most excited about in the field of psychosis? What are you seeing as really having the potential to improve lives and functioning in a positive way right now?
Two things, I'll say. One is that psychosis really is an opportunity to understand what really matters to people. So when your loved one develops psychosis, what is it about it that is really concerning to you as a mom or dad or sibling or partner? And it may be that they're not going to get married or they're going to lose their mind. It really gives you a sense of what matters. And what really matters, so culture can play a really important role in the study of psychosis, something that I wondered about early on, but it's a very rich way of understanding what matters to people. And the second thing is I'm just thrilled that we're seeing that people can lead full lives. And I must admit, I'm one of those people who learned this, that they can lead full lives and that there's a great deal of hope for individuals with psychotic disorders. They can marry, they can have careers, they can be parents. But the important thing is that they get the care and they get it early. And so those are the two things. One, it's a wonderful area of study to find out what matters to people and the role of culture. And secondly, that there's great hope for people with serious mental illness, something that we didn't think as much about in the past.
Well, thank you so much for joining me. I really, really appreciate it and love hearing your thoughts on culture. And I love hearing about this campaign that you're doing.
Okay.
This is Talking Heads.